really appreciate it. And I'm excited to be here as well to speak a bit about the work that I'm doing and the team that I work with is doing at OSU in the Suicide Trauma Reduction Initiative program. But we're going to focus primarily on this work as it applies to people with disabilities or the disability community, as I say more broadly here. So I am a scientist, so what that means is you're going to see lots of data and graphs. But I always like to start off at a broader level when we talk about disability and suicide. So if we just look at some stats here, we can see for kind of that left-hand side, I know it's a little blurry, but about 27% of folks in the US have some sort of disability. And if we think about people with disabilities as a minority population, this makes the disability community the largest minority group in the US actually. About 1 in 4 people have a disability of some sort. But that's not really the whole story either. A lot of times we conflate disability with age, thinking about mostly disability happening in older adults. But about 1/4 of people with a disability are under the age of 64. So if we're thinking about disability, really we should be taking a lifespan approach, because if we're not, we are actually excluding a lot of the population with disabilities. But there's more to the story than that as well. So disability occurs also not equally or proportionately across subpopulation groups. So there are differences by race as well, compounding our disparities that we see here. So that's a little blurry, but on that right-hand side, you can see, particularly along our American, Indian, Alaskan Native populations, particularly have highest prevalence rates of disability in the US. And like I said, love stats. So when we again think of disability, let's think about disability and suicide now at a broader level. Overall, some of my research and the research of my colleagues indicates that people with disabilities overall, the disability community has higher prevalence of suicide-related outcomes. So about 4 times as likely to have attempted suicide within a year. This is people with any disability-related condition. And what was found in this study is that as the number of disabilities someone has increased, because a lot of times people have more than one, the rate of suicide attempts skyrocketed to 8 times as likely for these individuals. And some more recent data from nationally representative samples, so from across the US, shows that people with disabilities have higher rates or higher odds of all suicide-related outcomes. So thinking about suicide, planning a suicide, and attempting suicide than people without disabilities. And those odds are about 2.5 times greater for the disability community than people without disabilities. So similarly, my findings are in line with that. A study I published in 2019 looked at whether people with disabilities have greater odds of having made a suicide attempt, but more importantly, if we think about transitioning from thinking about suicide to making a suicide attempt. So I looked at, compared to people without disabilities, do people with disabilities in the US are they more likely to have thoughts of suicide, and are they more likely to have a history of attempting suicide? And what I found is people with disabilities overall had 3 times greater odds of having attempted suicide in their lifetime than people without disabilities. And what I'll note for this that is really important is we didn't really necessarily always recruit on the basis of suicide attempts or suicide-related histories, but we're finding overall, even though we're not looking, recruiting for people with thoughts of suicide, that they are have these higher prevalences. So what this is telling us is, at a zoomed out view, the disability community overall is having a disproportionate burden of suicides. Again, there's more to the story though, but there's a lot that we don't know, unfortunately. So much more research is needed here. So I want to know, in my work and some of my colleagues' work, the how and why the disability community experiences these disproportionate rates. So one thing one study I always talk about, my colleague Emily Lund published a little while back is that suicide is actually seen as more acceptable in people with disabilities. In this study, participants were asked to read some vignettes. These were college students, to read some vignettes about people who were thinking about suicide. One person was maybe someone who was struggling a bit. They wanted to go on to become a doctor, but their grades weren't that great, so they were thinking about suicide. In another scenario, the same student wanted to go on to be a doctor, but they were going blind. Which person's suicide was rated as more acceptable? Well, I gave it away up here, but the striking thing here is that when the participants themselves have a disability or had a disability in the study, they still rated the person with the disability as their suicide as more acceptable. So what we're really showing here is there's something that's being internalized, or some beliefs that are happening. Ableism, we'll get to that. But what else is happening here? But also, like I mentioned, a lot of our work is focused on older adults, which is an incredibly important population because suicide rates are higher in the older adult population. Disability rates are higher in that population. But again, we're not taking a lifespan approach or looking at the disability community holistically. And because of that, there's also scarce representation of research on suicide across people with various disabilities or across disability types. A lot of the research is focused on people with vision impairment or people with mobility-related difficulties or people with multiple sclerosis. But we actually don't know about the disability community at large. Are there differences between these groups? Do some groups internalize beliefs differently or have different beliefs, different experiences? And how might that contribute to suicide risk? So a lot of our work is really focused on identifying whether suicide risk or increased rates and outcomes are present or absent, but don't actually look at what are the driving forces behind that, and what can we do about it. So that's a lot of where my work comes in here. So just to give you some kind of brief terminology before we go on, like I said, academics, we love very convoluted words. The first of which is that I find is really important in my work consistently is this concept of perceived burdensomeness. These are beliefs that people carry that are basically comes down to I am such a burden to other people around me and to society that if I died, other people would benefit more from my death than if I continued living. I consistently see these thoughts of burdensomeness or these beliefs that are internalized and heightened among people with various disabilities compared to people without disabilities. And I'm also seeing that it's consistently linked to thoughts of suicide. That's pretty consistent with the leading theories of suicide, that these perceived burdensomeness is a driving factor, particularly of suicidal ideation. I also am finding more stuff about felt stigma here. So my research has been moving to incorporating more kind of societal related beliefs as well. It's not just the internalized beliefs people carry, but what other people may say or do that can influence that. So with felt stigma, these are beliefs of, or fears of being stigmatized against, discriminated against in some way. Things like beliefs like people will treat me badly because of my disability. People with my disability lose their jobs. These beliefs are associated with people's belief or what they call their self-reported likelihood of rating themselves as more likely to think about suicide in the future and attempt suicide in the future. So these are folks that say, yeah, I could see myself thinking about suicide in the future. Or, yeah, I'm gonna make a suicide attempt eventually. It's gonna happen. And I find also that felt stigma isn't experienced equally across disability groups. So people with vision, blindness tend to have higher levels of felt stigma related to people with mobility-related disabilities. It might be, if we think into ableism, that there may be a bit of a, and research has indicated this, a hierarchy of disability acceptability, with people with low vision blindness being a bit lower on that hierarchy of what type of disability is acceptable or more acceptable. It's possible that some of this is happening and people are internalizing these beliefs. along with this belief of perceived burdensomeness. And in reality, it makes sense. Think about the media that we are bombarded with. So I love Netflix. I'll sit there and watch it all day. And there's a lot of problematic stuff out there. So think about if people with disabilities are 27% of the US population, how often people with the disability community is portrayed in the media. And when they are, what does it look like? Typically, it falls into a few categories. You've got the burden, right? I don't know if you've seen Me Before You. I'll spoil it the end for you because it's been a little while. But basically, the concept here is this person sacrifices themselves because their disability makes them such a burden. That sounds familiar, right, with what we just talked about. The idea of the superhero, their disability is a superpower. Not that they're just someone who's going out and buying groceries, but that this is someone, they have to be extraordinary, or the Paralympian. Or we have, the charity case, an object of pity. So I've got Tiny Tim there from A Christmas Carol. We've got even our, muscular dystrophy kind of marathons, or kind of like charity marathons. I've got that one up there, I believe. That people are paraded out an object to be pitied and for people to feel bad and give money. But think about how many times you see people, like I said, portrayed buying groceries, taking their kids to school, things like that, who have disability. In the media, it doesn't happen very often. These are more likely the types of tropes we're going to see. So at least from my perspective, it makes sense that some of these beliefs can be internalized if we're bombarded with this messaging on a pretty constant basis. Some more implicit or explicit than others. So it's time for us to rethink what suicide risk is in the disability community and how it comes about. This is some research that I received some funding to complete that really informs a lot of the psychotherapy work I do now and the trials I'm doing for the disability community and reducing suicide risk there. I've conducted a series of studies, and I won't go into all of them today, but basically I wanted to know a few questions here. The first of which is, do people who have disabilities, among this population across the US, do people's disability-related difficulties and really participating in various aspects of daily life? And so what I mean by that are being socially integrated in the community, going out into the community, being able to manage money or their finances by themselves, having like cognitive independence to make decisions. Do those factors play into suicide risk? Basically, does the disability itself impact suicide risk? Or is it something else that's going on? What type of internalized states or beliefs do people carry that might be most important in the relationship between disability and suicide? And is it possible that certain groups of people with disabilities are experiencing greater levels of these states than others? Or do they carry these beliefs more strongly or hold them more strongly than other subgroups of the disability community? So I mentioned some kind of brief findings a couple minutes ago, but I'll go into them a bit more here. And so in this study, I collected data from 127 adults from across the US. And in this study, they completed some phone interviews and some surveys online. And in this study, we had the majority of folks endorsed either having a vision, like low vision or blindness, or had a mobility-related disability, which can be, it's a very broad term, but I kept the inclusion criteria on the study broad on purpose. But I wanted to just let folks know that was most prevalent. This was about a middle-aged sample, so again, what we want to see, a mean age about in the 40s. So what I found here is that the disability impact, so super tiny text up here, so I apologize, but these, can people get around in their communities? Are the people able to get around from point A to point B, either using like a mobility aid or independently, without using any sort of assistance? They're able to manage their own finances, make decisions on their own. All of these things, are people able to, does that impact suicide risk at all? And so what I've actually found here, that's not the case. So a lot of disabilities themselves do not lead to suicide risk or do not impact how people think about suicide or see themselves as having suicidal ideation in the future. Really what's happening, again, is these beliefs of being stigmatized against or having having discrimination experiences happen to you. You internalize that. That leads to feelings of burdensomeness. And ultimately, people say, you know what, all this has happened, I could see myself thinking about suicide in the future or making a suicide attempt in the future. So it's important to know that, also that feelings of burdensomeness are a driver of suicidal ideation and suicide risk in the disability community. But what I actually found is it didn't differ across disability types or subgroups of the disability community. What I'm finding it's heightened overall. But like I mentioned, that felt stigma was experienced differently or disproportionately by folks with low vision or blindness. So just made the other note that I did look at recently in a study that was published this year, that people's beliefs about their own bodies were also experienced differently. So people with blindness and low vision did experience lower levels of body esteem, like positive beliefs about their body as a disabled person, than people who had mobility-related disabilities. And that did contribute to beliefs of having thoughts of suicide in the future as well. So overall, what I'm trying to get to here is not necessarily that, again, disability does not equal negative outcomes. Never want that to be the case, but, or let people think that. But really, what are the thoughts or the experiences leading to people's beliefs that are happening that are causing this to come about? So I see there's a question back there, yes.
Yeah, thank you. I was just wondering, are those with a disability such as bipolar disorder included in this research?
Yeah, so it's not exclusion criteria for our research. Was bipolar disorder something I was looking at specifically? No. But yeah, we keep our inclusion criteria very broad, because we want to include everyone. But for this research, we're looking at disabilities impact vision, hearing, dexterity, mobility, related disabilities.
Thank you.
Yeah. So again, like I said, it doesn't mean that disability equals negative outcomes. In fact, some of my colleagues have found the opposite. If we think about the disability community as a population, as a minority group with shared experiences, shared culture, we can think about what's called disability pride, disability self-worth. These are really important concepts that can bolster to protective factors against suicide. Things like having lower anxiety, depression symptoms, greater sense of belonging. So folks familiar with suicide prevention have theories. Having a high sense of belonging is important. We can bolster that by bolstering disability-related pride, having greater self-esteem, and noticing at the bottom adaptive responses to stigma. So this can help buffer when bad things happen. So if we want to think about treatments for folks with disabilities, the disability community, then we can also think about, are there ways we can really foster a sense of disability pride? What might that look like too? And I would be remiss if I didn't mention the pathway to suicide is not like this one-size-fits-all a thing. It's actually super complex here. So if we think of everyone like a glass of water, some people have more water in the glass, some people have less. Whose glass is going to overfill first? The person with the more water or less? This is a free response question for the audience.
More.
Yeah, more. So we think about baseline suicide risk the same way. That eventually, if people have more water in the cup, it can just take a little bit for them to tip over and suddenly we're in a crisis. And we've got to figure out how to solve that crisis. We're already here. It's very hard to do. So what we can do is use our evidence-based interventions to make sure that when folks are getting to the point where they're tipping over, we can use our skills to calm down the crisis. Really thinking about what are the individualized risk factors that this person carries, their historical water in the cup, but also what are the physiological responses people have when the water is rising, or what are the behaviors people do? What are the thoughts that are going through our minds? Typically, I'm a burden, my life isn't worth living, I'm worthless. These beliefs that we can target specifically with the work that we do here. And it does have a demonstrated effect on suicide risk. So just a quick plug for the STRIVE program at OSU. You can either Google STRIVE OSU, or you can, if you want to scan the QR code, takes us to your website. We do more than suicide prevention work. We also offer programs for PTSD, veterans, military personnel, or who were in law enforcement, or first responders are who we're most known for. But we've opened our groups to our work to the community as well, all across the U.S. You don't have to be in Ohio, and it's free. It's kind of the trade-off of participating in research. You get free therapy. We just ask you to fill out some surveys for us. But I just wanted to put that out there for everyone. One of the main interventions, or the one we are known for besides crisis response planning, which is the predecessor to safety planning intervention, is brief cognitive behavioral therapy for suicide prevention. It's a 12-session protocol that focuses on really, like I said, we might not be able to reduce the water in the cup, but we can figure out what folks can do to calm themselves down to prevent that cup from overflowing. But it's in a skills-based cognitive behavioral intervention here. If anyone treats PTSD, is familiar with like cognitive processing therapy, prolonged exposure, we have elements of that, both of those in there. But again, some more datas and graphs because they're my favorite. RCT was done originally with active duty Army soldiers for Carson, Colorado. And we found in this treatment protocol that people who receive BCBT compared to treatment as usual, and that doesn't mean nothing, it means whatever the clinic was already doing for suicide prevention, we see they had almost 70% less likely to attempt suicide during that follow-up period. And what this graph over here is showing is time to a suicide attempt. Top line is people in BCBT. And we see that, yes, some people in BCBT did attempt suicide. It happened less often, and it took longer for people to make a suicide attempt than in the control group. So people in BCBT, they had faster reductions, and they stayed better. We also saw good effects for suicidal ideation as well. And people in BCBT were hospitalized less often at follow-up than people in our treatment as usual group. So people in BCBT get better, they get better faster, and they stay better. And what's really great about this intervention is that it can be flexibly implemented. We have whole trainings on this, so I unfortunately don't have time to go into BCBT today too much. But because this intervention targets a lot of the beliefs that people hold, beliefs of burdensomeness, of worthlessness, guilt, shame, I wondered if we could apply this to the disability community, and thinking about including a lot of the cultural elements that are important to the disability community as well. So, especially from the knowledge from disabled creators, but also thinking about what are the participants in these studies? What are their experiences like? And really having them take the lead on a lot of things. So I received a grant from AFSP to basically to conduct a study called the Disability Suicide Prevention and Intervention Research Initiative. I have a iteration of BCBT that is delivered completely through telehealth, anyone in the US with a disability impacting hearing, vision, dexterity, or mobility. They get these sessions of BCBT, and I make sure that our materials are accessible, completely digital, screen reader friendly. Our exercises have been changed in a way that they can be completed with folks with various disabilities. So our mindfulness and breathing exercises may not work the same for someone who uses like a ventilator, for instance, or a breathing apparatus. But also thinking of ways to build positive disability identity in there as well as part of our cognitive thinking skills, and specifically targeting those disability-related beliefs felt stigma, perceived burdensomeness, that really heightened suicide risk. So, just to kind of give you an example of what the findings are so far, I'll say we have had about 38 people are currently enrolled, about 30 folks have gone through the study. So far, what we're seeing is what we want to see. So we have those drops in those beliefs of burdensomeness that are happening, especially, pretty quickly. So between baseline session 5, which is roughly about 5 weeks, because these are once weekly sessions, and it's happening towards the end of treatment as well. We're not looking longitudinally yet because this is a pilot study. And when we think about suicide ideation, good news, we are seeing exactly what we want to see. Reductions in suicide ideation scores every week. So what I'll note is by session 7 is where we see that significant difference. So a little halfway point for many folks. That dotted line, I just made that distinction there, is because we only had a few people that went out that far or needed a few extra sessions. So I just wanted to make the caveat there, that's a smaller sample size, a smaller part of the sample than the rest of the group here. So it doesn't necessarily mean people need like almost 20 sessions to get better in BCBT. Just means some people need a little extra, and that's fine too. So if we think about like a disability approach, then this is kind of like just a clinical case I like to have folks think about here. So this was an individual I saw completely changed all the details here. But I saw a Vietnam-era veteran with PTSD during my time in the VA. He's legally blind and uses a wheelchair due to a spinal cord disorder. And he recently attempted suicide by overdosing on prescription meds after experiencing some intense distress after watching a documentary about the Vietnam War. And after he's been discharged to the inpatient unit, it was referred to me, or pretend to your case, this is a hypothetical situation for you, for PTSD treatment. But he's still at higher risk of suicide, so you need to do some sort of safety planning with him. Those are typically done in written form. And you need to adapt the written homework component of treatment too, because these interventions that are typically manualized do have homework, do a lot of writing. What would you do? Is there any providers in the room? Like, show hands? Okay, great, we've got some. Any thoughts from anyone kind of what we could do in these situations? And you don't even have to be a provider here. What would work to make sure that this person's needs are met? Any thoughts?
So I work at the VA, and we actually have a VIST coordinator.
Mm-hmm. Yeah.
So I'd be consulting with her around what kind of adaptive equipment we have available.
Awesome.
I also work in the spinal cord clinic, so
Perfect.
there's tons of adaptive equipment.
Yeah.
Record a safety plan on his phone.
Yeah. So those are all great. So just kind of as what I did in this situation, I did actually ask him first, what would work best for you? Here are the options. Would recording work for you, or what adaptive equipment do you already have? How would you like to complete the homework? So he actually said, yeah, let's actually record, use a recording device for the safety plan. And we actually kind of tried different ways to do the homework. And he, had a VA provided him with like magnifiers and things. So his suicide risk scores, or his suicide ideation, was completely pretty much reduced by the end of treatment. No longer met criteria for PTSD either by the end of the intervention as well. But the point of this is not to like say, look at a great clinical job I did here, because like, he did all the work. But in reality, this is showing that we can adapt our interventions to work for our patients. And we can do it while being disability affirmative as well. So that includes, yes, our safety planning types of interventions, but also our traditional sit-down psychotherapies as well. A lot of that comes down to deferring to what the patient needs and relying on their own experiences. So I'm gonna go ahead and hand it over, but thank y'all so much.
Thanks. Well, thanks very much. While there's going to be a little bit of a quick